There's certain things that DBS will not work on. So if you have what they call atypical Parkinson's or Parkinsonism, so it's not true Parkinson's, then DBS won't work. So these are people that if you don't have a good response to dopamine or Cinemet, then you're not a candidate for DBS. And then if dementia, you're not a candidate for DBS because while you're going through the procedure, you have to be cognitive because you have to be able to communicate with the doctor. This is just an example of changes in on and off time with DBS, and you can see that it can go from 27% on time before the surgery to 74%, which is profound. Not everybody's a candidate for this, but if you are, it really can have a profound difference. 87% of the patients demonstrated improved motor scores in the off-medication state after 12 months. Here's a couple of... the one thing about DBS that improved, they used to do a couple of surgeries for Parkinson's, and they pretty much, I don't know if they do them anymore at all, at least the regions that I'm in, they pretty much DBS kind of replaced the thalamotomy and the pallotomy. Those surgeries were destructive. They would only could do them on one side of the brain. And so when your symptoms come on a Parkinson's, usually it's unilateral, but eventually Parkinson's is going to take over your whole body. And they used to, the old surgeries, it would actually destroy part of your brain to make the symptoms better. But eventually the symptoms came back and they overtook your whole body. They couldn't do them on both sides because it would cause you problems in speech and cognition. And so they're only unilateral and they didn't last very long. So the thing about DBS is that it's bilateral. So if you have symptoms, and eventually you will have symptoms on both sides, you can take care of, you can affect both sides with this intervention, and it's reversible because you don't destroy tissue. It's not destructive at all. And then they have you can fine tune it and program it. And I'm going to skip that video because I want to get to this. Is just a picture of the little. It's very similar to what I'm holding here. Okay, here's the good stuff. So physical therapy. Early intervention should always be the focus. And what I do a lot is probably the number one thing listed there is education on movement strategies. And I think that's where I get the biggest bang for the buck, how I help most people. And a part of that education is we do these other things, help you increase your range of motion, improve your posture, and ultimately try to keep you functional and moving and minimize falls. So this is a list of things we're going to go over. The first one is no more automatic pilot. And so prior to having Parkinson's, you didn't have to think to move. You just moved. You got up, you turned, you twisted, you walked, you poured your coffee. You didn't have to think about it. With Parkinson's, the automatic pilot doesn't work. We talked about that area in the midbrain. It was responsible for automatic movement. And it's faulty, and especially during times of your off periods. So when your medication's starting to wear off a little bit, that's when your automatic pilot, you can't rely on it at all. And that's when people get in trouble. And so what I do is teach people to turn off the automatic pilot, not use it, and to manually fly and drive the car, drive the plane. So the ability to move is not lost. So we talked about the basal ganglia. It's responsible for automatic, but you have another pathway responsible for movement, and it's in your motor cortex, which is in the front of your brain. That area is not affected at all by Parkinson's. And that's what you guys are going to need to use to keep on moving, to stay functional, to do things, and to avoid falls. And you have to train yourself to move purposefully. So this part of the area, it's opposite of the basal ganglia. It's not automatic, it's purposeful. And you have to train yourself to move purposefully. So these are some strategies that work well to kind of retrain yourself to move purposefully. And the first one is just kind of just basically visualize, what you're going to do. So if you know that you have problems getting into the car, getting out of the car, just visualizing already, you're starting to rev up your motor cortex, the purposeful part, you're starting to think about it. And you want to plan your steps, and you want to plan them one at a time. And you want to complete each step before you do the next one. And we're going to kind of talk about that. I'm going to give you some illustrations. But this is how you're going to start to make the conversion of relying on that faulty automatic pilot to actually driving the plane yourself. Blending movements, no more multitasking. Multitasking is terrible, terrible for Parkinson's. And the people that I work with they're very just great dynamic people or mover and shakers. I'm going to pick on one guy a lot because he's the most neatest guy, but he's the most multitasker. And I just got to keep on getting him to focus because if you multitask and you have the type of Parkinson's where you freeze, you're going to freeze all the time. So you got to quit multitasking. So you got to stay in the moment. And what this says is turn your patients into mental surfers. I'm from Hawaii, and surfing, that's one activity that you're in the moment. You can't be thinking about anything else when you got a big wave coming. You're not even thinking about standing up. I mean, you're just, you're in the moment. And so my goal today is to turn you guys all into mental surfers. A blending of movement. So this is one example of kind of a motor multitasking that people have a tendency to do with Parkinson's. And an example is that if you have progressed Parkinson's, this is pretty common to see people approach a chair like this. And what's happening here, it's motor multitasking. So instead of just, a normal approach would be to approach the chair, to turn, to reach back, and to sit, right? Those are all sequential tasks. You're going to do one at a time. Approach, 1, turn, 2, reach back, 3. The tendency for Parkinson's is to do them all. So you start turning, reaching, and approaching all at the same time. And that's when you get in trouble. So you got to do one task at a time. Everything has to be sequential. And if you think about it, you can do it. So I'll have somebody who is having a heck of a time with getting in and out of cars or chairs and do this. And I teach them to do it sequentially, and they have no problem at all. Because they turned off the automatic pilot, and they're driving the plane themselves. So this is just an example of one step at a time.